Good morning. I'm presenting demographics of patients with posterior circulation stroke who primarily presented to the ophthalmologist. Posterior circulation stroke involving the vertebrobasillary artery system account for 20 to 25% of ischemic strokes. And unlike anterior circulation stroke, these patients present with non-specific or subtle symptoms with visual disturbances being the most primary or sole complaint of the patient. And due to the visual symptoms, patients usually present first to the ophthalmologist. So early recognition of neuro-ophthalmic signs such as homonymous hemianopia and prompt referral for neurological imaging such as MRI and neurological consultation is essential for timely intervention and management and better outcome of the patient. The aim of the study is to evaluate demographic and clinical profiles of patients with posterior circulation stroke presenting first to ophthalmologists, to emphasize the importance of recognizing visual symptoms early, to improve interspecialty referral and reduce diagnostic delay, and to highlight the ophthalmologist's crucial role in stroke recognition. This was a retrospective chart review at a tertiary eye care center in Kerala, including patients presenting with visual complaints who underwent automated perimetry and had homonymous hemianopia on visual field testing. We excluded non-neurological causes of field loss, and data analyzed include demographic symptoms, ocular findings, visual field findings, MRI reports, and comorbidities. Posterior circulation stroke was diagnosed based on neuroimaging findings showing infarcts involving the occipital lobe, thalamus, brainstem, or cerebellum consistent with vertebrobasilar artery system. A detailed history and visual symptom documentation was done with comprehensive ocular examination, including visual acuity and fundus evaluation. Visual field testing using Humphrey Visual Field Analyzer was done, and MRI of brain was done for confirmation of posterior circulation infarcts, and assessment of systemic comorbidities was also done. We had 29 patients in total identified with homonymous hemianopia. 2 patients declined for further investigations. 8 were lost to follow-up, and of the 19 patients, 1 was diagnosed with occipital glioma in MRI and was excluded from the study. Of the total 18 patients identified with posterior circulation stroke, there was a male predominance of 94%. Most common age group was between 61 to 70 years. 56% had complaints of decreased vision, and other complaints included headache, giddiness, diplopia, field defect, imbalance, etc. 67% patients had left homonymous hemianopia, 28% had right homonymous hemianopia, and 1 patient presented with sectoral quadrantenopia. MRI showed 56% with right occipital infarct, 33% with left occipital infarct. 1 patient had small vessel ischemic changes, and 1 person was normal. 28% each patients had diabetes and hypertension, and there were other comorbidities like dyslipidemia, cardiac complaints, etc. Discussion: the eye is a window to the brain, and a thorough ocular examination will assist the clinicians to understand the mechanism of acute neurological deficits. And our study highlights the critical role of ophthalmologists in the early detection of posterior circulation stroke, especially when patient present primarily with visual symptoms. This aligns with broader observations. A study by Chaco et al. Had 710 new patients with 9 newly diagnosed CVA, 7 homonymous hemianopia, and 2 transient visual obscuration. And this underscores that posterior circulation stroke commonly present first to an ophthalmologist. Majority of patients were elderly males with commonest risk factors like hypertension and diabetes consistent with known vascular sex difference and risk profiles. Several studies have reported a higher stroke prevalence among men and may be due to the greater risk of hypertension, diabetes, dyslipidemia, and smoking in men compared to women. Visual complaints including decreased vision, headache, and visual fields were seen in the study, and this reflects findings from prospective cohort studies. Homonymous hemianopia was confirmed to be the most common visual impairment after stroke, particularly associated with occipital, parietal, and temporal lobe infarct. A greater occurrence of left-sided homonymous hemianopia was observed in our study, and this was noticed previously as well and may relate to hemispheric dominance and vascular anatomy of visual pathway. And 1 patient in our study presented with supranasal quadrantenopia, and this shows that incomplete and atypical field defect can still have a cerebrovascular etiology. MRI findings in our study revealed that occipital infarct in majority of patients, and this finding coincided with other studies where occipital infarct was found to be the most common MRI finding. This reinforces our observation that occipital lesions are the predominant finding on MRI in posterior circulation stroke patients presenting with visual symptoms, and reaffirms the role of neuroimaging in confirming the diagnosis. High prevalence of systemic comorbidities such as hypertension and diabetes reinforces the association between vascular risk factors and stroke. Multiple morbidity factors further complicates the clinical picture, especially in elderly patients, and necessitates an integrated care between the neurologist, intensivist, and ophthalmologist. Findings of our study affirms that ophthalmologists should maintain a high index of suspicion for posterior circulation stroke when patient complains of decrease in vision with a normal visual acuity on Snellens, especially when accompanied by subtle neurological complaints. Automated perimetry can serve as a clinical screening tool and can guide in timely neuroimaging and neurology reference and helps in better patient outcome through early intervention. The limitations of our study were that we had a small sample size with single center setting and loss of follow-up of patients and incomplete MRI data of some patients could introduce selection bias. Recommendations are that multi-center prospective cohorts is necessary to validate laterality trends and demographics and implement routine perimetry screening in your ophthalmology clinics with rapid MRI referral pathways and educate ophthalmologists and primary care physicians to recognize visual alarm signs for stroke. Conclusion, our study reinforces the indispensable role of ophthalmologists in identifying posterior circulation strokes, timely recognition of visual field defects, especially homonymous hemianopia, followed by urgent neuroimaging and neurological referral can markedly influence patient outcomes and ultimately reduce morbidity and improve patient prognosis. These are my references. Thank you.
Thank you, Doctor. Very interesting presentation, especially with regard to the laterality. Okay, so this is quite a straightforward presentation with occipital infarcts.
Yes.
And so, were you able to look at patients who had other features of stroke, like they might have been admitted elsewhere, or because it doesn't always present as a posterior cerebral artery infarct always. Many times it could be a middle cerebral artery and a posterior cerebral artery infarcts. So, where did you have any patients who was had a hemiplegia or something, who also had a simultaneous field defects and who presented to you later?
No, we would have had, like in the hospital, we have had patients like that, but in the study, we included
not.
those presented first to the ophthalmologist.
First to the ophthalmologist.
First to the ophthalmologist.
Okay. So, and you have listed out all the good way, other known variables, very nice, hypertension, diabetes, and other things as risk factors. Did you make a study or did you make the analysis for smoking? You have mentioned it in your presentation, but did you make an analysis because it significantly contributes to the increases the risk factor many-fold. So were you able to analyze the data? No.
No, so because since this was a retrospective study.
Retrospective. Okay. So it would have been useful to get that data because diabetes hypertension is okay, but then the smoking increases the risk many-fold in the presence of diabetes hypertension.
Yes.
So those risk factors should be clubbed and seen.
Yes.
And the other thing is, where was the infarct present in that supratemporal defect location? Do you remember? No. So where do we expect it? It's typically we describe it as a pie in the sky. So which location, which lobe? At least temporal lobe. So you don't remember which in that particular case. It doesn't matter. Okay. And the most important thing is how many were missed by any other ophthalmologist, because these patients typically do not present as field defect. They just present as that side I am not able to see. And the vision will be 6/6, and many times
Yes,
ophthalmologists will say that everything is normal for you because pupils are normal, fundus are normal.
That
It will
is
be
why-
useful to look into that's why.
That's why if patients complain and even if the vision is 6/6, we have to at least check their fields.
If the patients complain, we need to look into it.
Yeah, good presentation. So apart from the field effects, what were the other ophthalmological signs that you had elicited in these patients? Apart from field effect. Apart from the field effect, did you discover any other ophthal findings in these patients?
Mentioned infarcts were seen in the brainstem also in your presentation, if I remember. Elsewhere also, I think there is a mention in the
Yes.
this thing. So in that case, what would you expect? That's what
Yeah.
she is asking.
Okay. No, yeah, because you could be getting some gaze palsies and isoporias, and you need to look at
check the pupil assessment was done.
Yeah, that's what I'm asking, because sometimes other findings may also be there. Visual field defects is one thing. Apart
yes,
from that, you may get gaze palsies. I think sir would be able to tell
About
better.
giddiness,
Yes.
and other things you had mentioned. That giddiness could be also due to other brainstem
Then
lesions and other gaze palsies like vertical gaze palsies and other things, Q deviations.
Q deviations.
Those
Yes.
things could have been present. So posterior circulation stroke, by and large, the majority is the field effect, but then you will
Other-
also be, so you should be taking a larger sample size.
larger sample.
Yeah,
to
larger
look
sample
at it.
size, and also look into the other things which may also be there in this patient. Another thing is acquired CVI that can also be there. So I think you need to elaborate on the questionnaire a little bit.